Welcome to The Backstory with Dr. Ricky Singh. This podcast is focused on bringing you the latest research-based information about dramatically improving health, well-being, and quality of life. And here's your host, Dr. Ricky Singh.
A lot has changed regarding our understanding of SARS-CoV-2, which causes COVID-19, since when we first encountered this disease back in the winter of 2020. There's a great deal of information out there when we read about the disease, when we hear it in the media, and I think it kind of can confuse people, especially patients out there. So my goal today is to kind of talk about where we were 8-9 months ago, where we are now, and what the future looks like for this pandemic. And there's no one better to discuss this with than my guest. So my guest today is a professor of medicine and the chief of the Division of Infectious Disease at Weill Cornell Medicine. Please welcome Dr. Trip Gulick. Trip, it's great to have you here today. And when we started planning this episode, and things have changed significantly in the past couple of weeks, so I certainly want to try to be nimble in our content and see if we can touch on some of those points as well. So prior to 2020, I think the terms like social distancing, self-quarantining, and even pandemic, these weren't common terms that we used even in the healthcare setting. And now a conversation doesn't go by without mentioning one of these things, whether it's social distancing or pandemic. So just briefly, can you tell us about what is this novel coronavirus? Why does it spread so quickly? And just some basics on what we're dealing with.
Sure. So the family of viruses called coronaviruses are not new. We've had coronaviruses for decades, but the ones that we've had have been relatively mild. They cause probably 10 to 30% of upper respiratory infections in any one season. So many of us have been exposed to these. We really didn't pay a lot of attention to the coronaviruses until 2002. That's when the original SARS outbreak occurred, and what was different about that coronavirus was that it caused respiratory failure, and that was new. So we'd never seen a coronavirus that worked that way before. There were concerns about a global pandemic back then, if you recall. Basically, public health measures were able to stop that from happening. It's kind of interesting that we haven't seen SARS, the original SARS, return in the last 18 years. Fast forward 10 years, and we go to the next serious coronavirus, which is called MERS, which stands for Middle East Respiratory Syndrome. It's been linked to exposure to camels, and it can actually cause severe respiratory illness as well. There still are sporadic cases of MERS. Then we come to a brand new disease. We've never seen this before. December 2019, there is an outbreak, a cluster of pneumonias in Wuhan, China. And they looked at that and reported it very early on to the WHO. They quickly isolated the virus, and this is a new human virus called SARS-CoV-2. And they sequenced the virus and quickly developed a test for it. What happened with that outbreak is we know it spread from person to person, rapidly spread through all of China, and then on to Europe, and as we now know is worldwide. The definition of the word pandemic is an epidemic that affects every country and region of the world. So COVID-19, the disease caused by SARS-CoV-2, is truly a pandemic.
It's fascinating what you described in 2002 when we first encountered a similar virus to the one we're dealing with now. Why is it that this particular SARS-CoV-2 has spread so quickly? Is it because of the public measures that we haven't taken similarly to 2002 and the 2012 outbreaks?
So it's a combination of things. One really important factor that's unique to SARS-CoV-2 is that the levels of virus in a person's nose and throat gets very high up to a day or two before they develop symptoms. So unfortunately, what that means is that completely asymptomatic people can spread this virus to other people not knowing that they're sick. Contrast that with the original SARS. The levels of virus in the nose and in the throat did not peak until a week into the illness. So fundamental difference there. And then, of course, as we know from looking around the world, it depends on what kind of public health strategies are employed to try to avoid person-to-person spread.
Certainly the incubation time probably has a role in therapeutics and even in vaccine development, which we will discuss in a moment. When we first encountered this, or at least me, not in the infectious disease world here at Weill Cornell, New York Presbyterian, back in March of 2020, we had a lot of physicians and faculty redeployed into the units, and their experience and their reports coming back to the department are certainly different today than what they were 8-9 months ago. So what do we know now about COVID-19 that we didn't really know 8-9 months ago?
Well, we know quite a bit. The first is it was originally thought of as a respiratory virus, which, again, we have significant experience with, that could lead to severe respiratory complications. We now appreciate not only does it do that, but it can lead to multi-organ system involvement, meaning that people can get heart disease related to it, kidney issues, liver, neurologic issues, and others. So this can be quite a devastating illness for some people.
I recall, when patients were coming into the hospital, just like you mentioned, we thought it was a respiratory illness. We would put patients on oxygen pretty early and then, unfortunately, quickly lead to intubation and ventilator support. Has that changed recently with the new therapeutics that we have to offer in the hospital setting?
So we have made significant progress in the last 9 months. Originally, back in February, March, April, we actually saw our first case in New York State March 1st of this year. We really had nothing to offer people. The only thing we had to offer was supplemental oxygen and support. We had no specific treatments for COVID-19. That's come really quite a long way since then. We now have one FDA-approved drug. It's the antiviral drug called remdesivir. We were involved with those studies right here at Weill Cornell. We also have one drug that has been shown to reduce mortality, and that's a corticosteroid, dexamethasone. And these two agents together have led to improvements in how we manage COVID.
It's fascinating to hear that here in 2020, at Weill Cornell, New York Presbyterian, top 5 health institution in the world, we had nothing to offer patients for this disease because it was so new, so novel to healthcare in general, and to see where we've come in just a short period of time, 8 months, is fascinating. One thing we don't talk a lot about is health inequities. And, coronavirus, COVID-19 is not different in how patients get access to health care. And we know that there are racial and ethnic minority groups that are increased risk of contracting this disease and probably not getting care, leading to increased rates of death. Can you speak a little bit to who are these racial and ethnic and maybe even health-related minority groups that are unequally affected by this disease?
Yes, this is a very serious issue. So not all people are affected by SARS-CoV-2 and COVID-19 to the same extent here in the United States. We know that communities of color, particularly Latinx and African American communities, have higher rates of infection, higher rates of hospitalization, and higher rates of death. When you go back and look at what the causes of this difference are, there are probably several. The most important may be social factors and disparities that we've seen in healthcare for quite some time. Living situations can be different, so the number of people in the household can be more or less depending on race and ethnicity. And then who is a frontline worker today? And I don't just mean in healthcare, but workers all across the spectrum. And communities of color are overrepresented in frontline jobs, so more susceptible to coming in contact with the virus. And then the traditional healthcare disparities, not having as ready access to healthcare and hospitals as other groups.
And some of the risk mitigation strategies that we try to implement anyway, like self-isolation and quarantining, that probably unequally affects this group of patients as well, seeking health care if and when they do get sick.
Sure, and if you live in a household where there are 4 or 5 other people, it's really difficult to participate in some of these strategies like isolation. Where do you go? New Yorkers, we all live in small apartments here. It's tough to really quarantine a family member if you live with a number of people.
Absolutely. Another subset of the population that we don't talk a lot about, I don't, you certainly do, is the immunocompromised. And that doesn't mean just patients with HIV or human immunodeficiency virus, but also those with autoimmune dysfunction, lupus, and things like that. How is that group of patients affected by this coronavirus?
Right. So there are certain groups that are more susceptible to severe COVID-19. And the biggest group that was realized early on were older individuals. People sometimes say, well, what's older? What cutoff do you mean? It turns out it just rises with age. So you could say above 50, 60, 65, certainly above 80 is where you see some of the most severe COVID cases, and death rates are highest in that group. Alongside with that are people who have underlying conditions. So what are those? Originally described from the Chinese groups, we know that diabetes and heart disease are two major factors that predispose to more severe disease. When the epidemic came to the United States, obesity was added as one of those factors. And we now know kidney disease, liver disease, lung disease, and as you mentioned, immunosuppression. So having your immune system dampened down for other reasons, whether it's a viral infection like HIV, or you're taking medications to control an autoimmune condition or cancer, that can predispose to more severe COVID-19 as well.
When we first heard about it, or I did, I have asthma. I take a corticosteroid inhalation every day. So I was very concerned about coronavirus because, like you mentioned, we thought this was a respiratory disease. And what we were finding, especially in the hospital, is that it wasn't the asthmatics or even patients with pulmonary disease suffering. It was the patients with vascular disease, diabetes, obesity, heart disease, and things like that. So you certainly speak to what we've learned over the past 8 months regarding the treatment of this disease. In terms of therapeutics, we've heard a lot of things over the past 8 months in the media, starting with chloroquine and hydroxychloroquine and cortisone, protease inhibitors, and now antiretrovirals. So you co-chair the NIH COVID-19 treatment guidelines. Like you mentioned, you've done a lot of work here at Weill Cornell regarding remdesivir as an approved therapeutic for COVID. Can you kind of tell us about different therapeutics that are available and even the work that you've done with remdesivir?
Sure. So COVID-19 is a progression of stages. As we mentioned, someone gets exposed to the virus. Within around a week, they may develop symptoms. At that time, the levels of virus in their upper airway, their nose and throat, have already gone to very high levels. That's an opportunity we know from other viral illnesses like influenza that antivirals, drugs that specifically target the virus itself, might be most efficacious. Then a person with COVID may continue to progress clinically. And COVID is a potent stimulator of inflammation, and there's something called the cytokine storm, meaning that this virus has now provoked the immune system to rev up and to work in abnormal ways. And this can flood a series of compounds called cytokines, which are hormones that get inflammation going. This can rapidly progress to respiratory failure and cause multi-organ system disease. And so, unlike the antivirals, which may work early, there's a whole nother set of therapies called immunomodulators. That is, they affect the immune system. And what we're trying to do there is either dampen down or interfere with this immune response, which is not a positive immune response. It's actually causing organ damage. So those are sort of the two approaches we take today, antivirals earlier and then immunomodulators later.
Using that logic, is there safe to assume that there would be some protection in the immunocompromised patient because they won't have this cytokine storm like someone with the full immune system might develop?
Well, that's an interesting question that people have looked into, but this is a viral infection, and so we know you need an intact immune system to fight it off. What we're talking about is really dysregulated immune response, and that's this whole concept of a cytokine storm. So immunosuppression actually doesn't help save you from that. It can predispose you because viral levels can even be higher.
So we've kind of talked about where we were 8-9 months ago, the therapeutics that have been in the works and developed recently. And I want to kind of talk about where we're going to go and where you opine as where this pandemic will lead us. The global impact of this virus has been tremendous, but so have the efforts in trying to stop it. There are more than 140 different vaccine candidates, and just recently in the news with Pfizer and Moderna, we've heard of two that have shown 95-ish% efficacy. Can you comment on what does this mean? What does 95% effective mean, and are these results promising that we've heard about?
Sure. So we know from other respiratory illnesses like influenza that vaccination works. And even if it doesn't prevent infection, it can make the disease, if you get it, less severe. And that happens with flu today, and that's why we recommend flu shots for everybody. If you've seen the structure for the coronavirus, you see these little spikes on the surface and these particles. It's called the spike protein. And it looks like a crown sitting on top of someone's head. Coronavirus, that's how it gets its name. It turns out that spike protein is what stimulates the immune system, our immune systems, to make a response. So we make antibodies to that to try to neutralize the virus, and we make cells of our immune system to try to, again, neutralize the virus because they're recognizing the spike protein as being a foreign substance. So that's the thinking behind a vaccine. Could we give someone a version of this spike protein, not the whole virus, but just that protein, and stimulate their immune system to develop a response? And then if that happens, if they ever do get in contact with the SARS-CoV-2 coronavirus, their system is already primed to neutralize it. That's the approach in vaccines, and it is called from the NIH the warp speed program, and that's because it's going so fast. So typically, the time it takes from the identification of a vaccine to the approval of a vaccine can be 10 to 15 years. Well, we don't have time for that. And so everything is being shortened in this era of COVID-19. The good news is there's more than 200 vaccines that have been developed. 6 of these have gone into advanced development at this point, 5 of them co-sponsored by the NIH in terms of support. And as you mentioned, 2 of them have actually reported very significant results. So the 2 farthest along use an approach we've never used for vaccines before, and this is called RNA vaccine. So RNA is part of the genetic material of this virus. It's what the virus uses as a template to make its own proteins. So in this case, the Pfizer and Moderna vaccines, those are the 2 farthest along, actually inject a sliver of the viral RNA into the human system. Your body picks up the RNA and then uses that to make the spike protein, not the whole virus, but just the spike protein. So it primes the immune system. Your immune system recognizes this and says, whoa, foreign invader, let's neutralize, makes antibodies and cells, and that's how the vaccines work. So it's actually injecting RNA into your muscle cells. We've never had a vaccine that's an RNA vaccine before. You might say, well, why would you do that now? Turns out RNA is relatively easy to make, and so they can really gear up. And that's part of the reason that the development of vaccines has been shortened. These companies are already making millions and millions of these vaccines, even though we have incomplete information about how well they work. And then very exciting this month, in the month of November, we've heard the first readout from both the Pfizer vaccine and the Moderna vaccine. Now, what they did in the advanced development in these studies, and we were involved here at Weill Cornell with the Moderna vaccine study. Pfizer enrolled 40,000 people, Moderna enrolled 30,000 people. Half got the vaccine, 2 doses for each of these. Half got a placebo shot, meaning no medication, no vaccine in there. And then they followed people for who developed COVID. So we heard preliminary results, just under 100 cases on either the Pfizer or the Moderna studies, They looked at 100 confirmed cases of COVID in the study participants and then went back and looked, well, how did they distribute? And it turns out that the vaccines were 90 to 95% effective, meaning there were very many fewer cases of COVID in the group that got the vaccines directly compared with the group that got the placebo.
In addition to the vaccine, were those patients still practicing risk mitigation measures? Were they wearing a mask? Were they social distancing at the same time?
Yes, that was part of our obligation, is to inform people, look, we don't know if you have a 50-50 chance of getting the vaccine or not. Also, we don't know if this vaccine works, so you need to do everything to protect yourself. So we give them the same advice we give to everybody. Wear a mask, socially distance, and wash your hands frequently. Nevertheless, with the current COVID outbreak, which we're all aware of, people did get the infection. And then, again, you go back and count them up, many fewer infections in the group that got the vaccine. So that shows us that these vaccines prevent COVID disease.
Here at the hospital, we get the flu shot every year, presumably because the antibodies or the response from our immune system doesn't last forever. Do we anticipate a similar response with this new coronavirus vaccine?
So there's two issues. One of the reasons why we have to get the flu shot every year is because flu virus mutates quickly and changes itself. And so the target for the flu virus are proteins on its surface, and they change from season to season. That's one reason. Interestingly, SARS-CoV-2, this coronavirus, does not have a propensity to mutate. That spike protein really doesn't change over time. So that's good news. It may mean that immune system can be effective longer term. But the second element is, how long do antibodies last? And we know just from following people who've actually gotten COVID-19 that a certain proportion of people will begin to lose their antibodies even 3 months out from the infection. And what that means is, in the natural situation, is people can get it again. And so there's been well over 100 well-documented reinfection cases worldwide, people who've gotten it again, and at least one of those people died from getting it a second time.
So I think that's a really important point. I feel that in the media we hear of patients or people getting coronavirus, getting antibodies, and kind of feel bulletproof from getting this infection again. And I think you've answered that question, that you're not immune forever. The antibodies may phase out and you might be susceptible. Let me ask you another question about the vaccine. So the vaccine can help prevent severity of infection. Does it affect the ability to transfer or transmit the disease from one person to the other, even if you've been vaccinated?
That would be an important result, and we actually don't know that fact yet. They're going to go back and look at people and see if the vaccine also decreased carriage, that is, having the virus in the nose and throat, but we don't have those data yet.
Similarly, someone who's been infected, who does have antibodies, they could still transmit the disease from one person to someone who may be susceptible to getting a severe illness.
Well, we know that's true, again, from the natural infection. People develop antibodies about a week to 2 weeks after developing symptoms, so they still have the virus in their nose even when they have the antibodies. So those are two really separate things that one has to think about.
Given the results of the Pfizer and Moderna studies, are you optimistic that there's going to be some type of durable solution or foreseeable end to this pandemic?
So we heard the interim results from both of those studies, and just 2 days ago, Pfizer now has the complete information from their very large phase 3 study. The trend continued. So they analyzed 170 total cases, and all but 8 of them were in the placebo arm. So the vaccine, the Pfizer vaccine for COVID, was 95% protective. That's a really important result, and those data, along with the fact that only mild side effects occurred in people, that's enough for them to go to the U.S. Food and Drug Administration, the FDA, for review, which they are planning to do. In fact, they may have already done it. The first thing the FDA is going to do is consider whether this vaccine should now be available through a program called Emergency Use authorization. What is that? EUA, it's known as. So this is a program where the FDA can make an investigational drug or vaccine available even before it's approved. And all it has to do is show the suggestion of efficacy. So it doesn't have to be proven like it would be for full FDA approval. So Pfizer has announced that they are seeking EUA approval for their vaccine, and if the results stand up the way they appear to be, we should expect that that would happen. At the same time, they'll go for full approval from the FDA. That could occur quite rapidly given the attention and the concern here. So it's possible we'll have an FDA-approved vaccine pretty early in 2021. Moderna is just one half step behind. They're about to do their final analysis as well. They showed in preliminary information 95% effective. Again, if that holds up, we'll have 2 vaccines available in relatively short order.
I mean, that all sounds encouraging. Certainly we have to be cognizant of how we're going to distribute this across the 300 million plus people in the United States. I'm sure the Department of the Defense or the CDC has some algorithm on who would get the vaccine and in what order. Is that enough? Is the development of this vaccine sufficient to stop this pandemic? Or are there other factors at play, whether it's herd immunity or antibody therapy and things like that? Where do you see the end to this pandemic coming?
I think the vaccine is going to be one giant step in the right direction. And the good news is both those companies have already made millions of doses of their vaccines, and both are projecting upwards of a billion, that's with a B, doses available in 2021. So if that's true and it all works out and there aren't concerns about it, then much of the population can be vaccinated. And if that happens, then you begin to think about this concept of herd immunity. What is that? It means when you look at a population, in this case humans, when enough of the humans are immune within a population, then the infection doesn't get spread anymore. Most estimates from prior infections put that number somewhere around 60 to 70%. So you need 60 to 70% of the population to be immune to an infection to really wipe out transmission for the other 30% and essentially stop the infection in its tracks. So perhaps we're headed in that direction. That would be my hope. Until we get there, we got to keep doing the real basic things. The 3 W's: wear a mask, watch your distance, and wash your hands.
Is there a group of patients that may not be able to get this vaccine due to some type of underlying health condition? Is it the immunocompromised, an elderly individual, or can everyone receive this once it's available?
So the issue is that some people have other illnesses, particularly people with immune compromise, where they don't make antibodies. And so that would be a concern. You would not expect them to respond to the vaccine. They wouldn't make the necessary immune response. So we need other approaches for that group. The good news is that we are looking at antibody preparations, whether it's convalescent plasma. That means that you go to someone who's recovered from COVID, isolate their plasma, and it has antibodies inside, so they're preformed, and then give it to someone who can't make antibodies to try to protect them. That strategy is being explored, including here at Weill Cornell. Or you synthesize the antibodies, so they're called monoclonal antibodies. They're synthesized, they bind to that spike protein and prevent the virus from binding to the cells. And that compound, the first one's out of the gate, not yet approved, but available again by an EUA as an investigational agent. And it's called bamlanivimab. Just rolls right off the tongue there, affectionately known as BAM. And so this could help people who don't make antibodies themselves.
So given about 60 to 70% of the patients it's required to develop herd immunity, even if we do that and there are still those individuals who cannot get the vaccine, presumably we can still see an end to this pandemic, given the convalescent therapy, the antibody therapy, and the vaccine.
That's the hope here.
Let me ask you a question. If and when the vaccine is available, And based on what you've read about the results, would you get the vaccine?
Absolutely would. And I'm saying that because, number one, these two vaccines both look efficacious, 90 to 95%. That's as good as almost any vaccine we have for any other illness. So these are good vaccines. In fact, surprisingly good. Sometimes the flu vaccine that we all take every year can be only about 30% effective to either avoid the disease. But recall, even with flu, if it doesn't help you avoid the disease, if you do get the flu, you get a milder case because of the vaccine. But the other critical part is, what about the safety of these vaccines? The good news is that we have data on 70,000 people in these two studies put together, and they've been followed now for several months. Well, that's not forever, for sure. They're going to be followed for a period of years to make sure that no surprising side effects will turn up. But in general, the vaccines that we have are very safe, and these two, at least in the short term, look safe. So I'm convinced enough about the data I've seen already, particularly with the threat of COVID-19 in the community right now. So I would recommend everyone get this vaccine. As you mentioned before, it's likely to be a staged approach. So healthcare workers and those most vulnerable, older people or people with underlying conditions, will be prioritized.
You know, listening to you, I mean, you can't see because I'm wearing a mask, but I'm smiling. You've given me hope. I hope the listeners are taking some hope away from this. You know, watching the news and the media, it gets depressing just to see the COVID numbers rise. I think it's important to still maintain those risk mitigation strategies that you talked about, the 3 W's. Wear a mask, social distance.
Watch your distance.
And wash your hands. So I certainly appreciate you sharing that with us. You know, we're in the middle of holiday season. Thanksgiving just passed us, and now we have the upcoming holidays and the New Year's, and a lot of individuals are going to be traveling. What are your thoughts on flights, airport travel? Can you do it safely or avoid it at all costs?
I think this is the year that people should not travel. This is going to be a Thanksgiving and holiday season like we've never seen before. And people really need to take this illness seriously. Any kind of travel puts you at some risk. Whether you're driving your own car, you still got to stop and get gas, you got to go to the bathroom, or you're taking a bus, a train, a plane, you got to go to the station. You're surrounded by people you don't know. Some of them may not be wearing masks. I mean, you can try to protect yourself, but the safest thing this year, and what everybody is saying, is try to travel as little as possible. Don't travel for this holiday season. Vaccines give us hope that maybe next year will be different, and so we can still see our families, but this is not the year to get big family gatherings or big groups of friends together to celebrate.
All right, well, listeners, you've heard it here first from the mouth of the expert on traveling this season and other ways to minimize your risk getting exposure. So, Trip, it was a pleasure. Any final thoughts for our listeners on how they can stay safe during this holiday season?
Use basic common sense, and don't forget those 3 W's. They're worth repeating. Wear a mask. We know masks work. Don't get thrown into the controversy about them. They absolutely protect the person wearing them and the people around you. Watch your distance. Distancing actually works. So separate. Try to not be in a big group of people. Limit the size of the groups as much as possible. And lastly, wash your hands. And that will not only protect from COVID-19, but also influenza.
Well, Trip, thank you for spending time with us. You are an expert in this field. The work that you've done here at Weill Cornell, New York Presbyterian, on developing therapeutics and your work with the vaccine is tremendous, and we certainly appreciate that. Thank you for taking the time. I hope the listeners have enjoyed this as much as I have, and I've certainly learned a lot.
Thanks a lot.
Thanks, Trip.
Thanks for listening to The Backstory. Please subscribe, rate the podcast, and review The Backstory on Apple Podcast, Spotify, and Google Play Music. And feel free to share this podcast on social media or even your own website or blog. This podcast is for general information purposes only. It does not constitute the practice of medicine, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information is at the user's own risk. The content of this podcast is not intended to be a substitute for medical advice. To learn more about Dr. Singh and his clinical research, please follow him on social media. You can also sign up for his newsletter by going to www.rickysinghmd.com. That's RICKYSINGHMD.com.